Okay, let's get started with Chapter 3 of the podcast. This particular chapter is entitled The Pharmacist and the Pharmacy Profession. There are 24 pages in the textbook that we'll be covering with these 23 slides in this presentation. There are 9 objectives, and a lot of this covers some of the history and the progression of our profession. We'll also describe some of the professional pharmacy organizations and the roles and functions of pharmacy technicians. We'll describe some of the technological advances and the implications of the pharmacist workforce changes going on. As far as the evolution of our profession since before the 1940s, before World War II, the beginning of the 20th century, there were no credible standards or enforceable laws regarding the safety of therapeutic agents. The Pure Food and Drug Act of 1906, which is one you're going to have to remember for your law course in the third year, was not very comprehensive. There were many loopholes, and it did not address efficacy. The elixir of sulfanilamide scandal in 1937 provided the impetus for the Food, Drug, and Cosmetic Act of 1938, which has since essentially replaced the 1906 Act. In here we talk about it a little more. The sulfa antibacterial was safe and used for years, but a new oral preparation was made with diethylene glycol, which is antifreeze. It caused about 100 deaths. Some were children. There was no law, so the manufacturer was only fined for improper labeling of it as an elixir instead of a solution. The public outrage spurred passage of the FDA, Food, Drug, and Cosmetic Act. Going on, the Food, Drug, and Cosmetic Act afforded more authority for enforcement to the by the Food and Drug Administration through the approval of new drugs and indication and standards for safety and efficacy. Drugs not yet categorized, they weren't at that point categorized into either prescription or non-prescription. That was later in the 1950s. Frequently, pharmacists were the first source of healthcare advice and medication recommendations, so pharmacists had indirect prescribing authority even before World War II. Between World War II and the 1970s, there was this era of expansion. There was the Hill-Burton Act of 1946, which provided monies for hospital construction and renovation. In 1951, the Durham-Humphrey Amendment to the Food, Drug, and Cosmetic Act created prescription drugs. It essentially gave pharmacists a monopoly on the distribution of drugs. And in 1965, the addition of Titles 18 and 19 amended the 1935 Social Security Act to create Medicare and Medicaid, respectively. Medicaid for the elderly and Medicaid for poor indigent folks. Also, between World War II and the 1970s, there was a change in the pharmacy curriculum. It went to the BS degree from 4 to 5 years. The expansion of the didactic scientific curriculum to include medicinal chemistry, physiology, pharmaceutics, pharmacology, and pharmacokinetics. This further legitimized pharmacy research and practitioners due to rapidly evolving drug therapy innovations. So pharmacy was becoming much more professional into the 1970s. From the 1970s to present, there were different articles and different studies made. The mirror to hospital pharmacy. There was some suggestion that pharmacy had lost its way in producing professionals. The Dichter Institute study, more respondents saw pharmacists as businessmen rather than health providers. And the Millis Commission report in 1975 said that pharmacists were inadequately prepared in systems analysis, management, and communication skills. By the way, I should point out for the quiz, an IRAC question, I would point out that there were things that marginalized the pharmacist's role during the middle of the 20th century, and these things were rectified in the 1970s and on. That included the APHA Code of Ethics, which essentially forbade a pharmacist from interfering with what the doctor said. There was now a mass production in prefabricated drug products, and pharmacists were just starting to dispense more and more, faster and faster. And the designation of legend drugs by the Durham-Humphrey Amendment, such that pharmacists couldn't really counsel patients, but they could distribute these legend drugs. So all of those things helped marginalize the pharmacists during the middle of the 20th century. The profession blamed itself because of a large multi-service pharmacies, which de-emphasized training, expertise, and patient care. You started to see pharmacies with like lawn hoses, hardware, soda fountains, and such. Clinical pharmacy movement rebranded the profession as therapeutic advisors. College started to increasing the number of post-BS PharmD programs for clinical pharmacists, primarily practicing in hospitals, providing pharmacokinetic dosing and drug information services. And later, as we got into the 1990s, the PharmD became the entry-level degree. Also going on at this time was the organization of HMOs. In 1973, the Act increased the prevalence of managed care and cost containment. Diagnosis-related groups called DRGs for short created a taxonomy for Medicare patients, setting a prospective reimbursement schedule for disease states and conditions, regardless of the length and intensity of care. So Medicare patient, for example, who was admitted to a hospital, the Medicare would pay that hospital an agreed on rate or reimbursement for that patient, no matter how long they were in the hospital or how much care they needed. DRGs created an incentive for hospitals to discharge patients sicker and quicker, because essentially if the hospital didn't get them out quick enough, they would eat the cost. Pharmaceutical care, among the things that you're going to have to read for this particular chapter is an article I included on your Canvas module involving a manuscript, an article that was published in ASHP by Hepler and Strand called Opportunities and Responsibilities for Practicing Pharmacists. Essentially, when Hepler and Strand wrote this, clinical pharmacy still focused on products and services rather than on the patient. Medicalization and increased reliance on drug therapies had adverse effects called drug misadventures, as well as benefits. So here are some of the things that happened. These drug misadventures, ADRs, hospitalization, patient noncompliance, and deaths. Pharmacy accepted the mandate of pharmaceutical care as articulated by Hepler and Strand in that article I've asked you to read. Pharmaceutical care, which you should probably memorize, this definition is the responsible provision of drug therapy for the purpose of achieving definite outcomes that improve a patient's quality of life. Outcomes being cure of disease, elimination or reduction in symptomatology, arresting or slowing the disease process, and preventing disease or symptomatology. The basic functions are identifying potential and actual drug-related problems, resolving actual drug-related problems, and preventing potential drug-related problems. Now, it is confusing for some pharmacists who've been practicing for a number of years like me, the difference between the term pharmaceutical care and medication therapy management. MTM is similar to pharmaceutical care. It emphasizes the importance of medications in public health and safety, yet recognizes the inherent collaborative nature among pharmacists with other healthcare professionals to achieve these goals. Clearer models for its implementation and resultant services have been preferred in comparison to the previous model of pharmaceutical care. Now, what I would simply say is that MTM is essentially pharmaceutical care, but that it's provided by more than just pharmacists. It's a term that was coined by Congress when it enacted OBRA 90, which is essentially the law that mandated that pharmaceutical care be provided to all Medicaid patients, and eventually at the state level was mandated for all patients. There are barriers to pharmaceutical care, those being these 5 here, the focus on drugs, products, the service function, there being other healthcare professionals that see it as turf war, lack of incentive, compensation based on dispensing productivity rather than patient care, and logistical. Pharmacies were not designed to do consultations, disease monitoring, and providing drug information. Now, one of the things I would point out is that the Board of Pharmaceutical Specialties, the acronym being BPS, has certification to help pharmacists be recognized as specialists in pharmacotherapy, nutrition support management, or pharmacy and oncology pharmacy. There is no certification for diabetes management, for example. That would probably fall under pharmacotherapy, a very broad specialization certification. Also, when you're talking about barriers to pharmaceutical care, there's the issue of reimbursement. The Medicare Prescription Drug Improvement and Modernization Act of 2003 created Medicare Part D, It has language that positions pharmacy as the natural choice to provide pharmaceutical care services. These services are envisioned but not mandated nor reimbursed. It should be noted that about that time, there was the Asheville Project that took place in the western part of North Carolina, up in the mountains. It was an ongoing private sector venture whereby pharmacists are reimbursed for pharmaceutical care services. Initially for diabetes, it went on to like asthma, and it has proven to improve outcomes and save money when pharmacists are paid to do these kinds of services. So I would emphasize for a quiz question that pharmacists have demonstrated the ability to promote positive outcomes when reimbursed for pharmacy care services. They are not reimbursed primarily through the provision of cognitive services. The federal government does not recognize pharmacists as disease educators for reimbursements process or purposes. And reimbursement to pharmacies rather than pharmacies is not more likely to facilitate the implementation of pharmacy care services. You need to reimburse pharmacists, not pharmacies. There are different pharmacy professional organizations. The one that is most prominent is the American Pharmaceutical Association back in 1852. It's now known as the American Pharmacists Association with state affiliates. So like here in New York State, we have a state affiliate. The American Society of Health System Pharmacists, primarily for hospital-based pharmacists, and the Academy of Managed Care Pharmacy, AMCP. All of these function to serve the interests of their members. Benefits and services of these organizations is publications, research, profession updates. They help pharmacists maintain their competency through continuing education and professional meetings, career planning assistance, financial benefits, and participation in governance within the professional lobbying, especially the APHA. One thing I would also mention is that there are a lot of pharmacy manpower issues out there in the United States right now. And these organizations, as far as manpower, there are implications for things like pharmacist salaries and benefits, medication safety among patients, and the ability of the profession to provide pharmacy care services. And all of these are part of the lobbying that these organizations do. And again, you may see this on the quiz, what these pharmacy manpower has implications for. Again, continuing with the different pharmacy organizations, there's corporate memberships in the ISMP, the NACDS chain drugstore or association, PhRMA, the Pharmaceutical Research and Manufacturers Association, and in the GPHA, the Generic Pharmacy Industry Association. As far as education and regulatory issues, these pharmacy organizations, the 5 under here, are really important for education and regulation. First, there's the National Association of Boards of Pharmacy. If and when you want to reciprocate, you will get to know in ABP. You have to pay a fee to reciprocate. You have to go through them, as well as the 2 state boards involved. The ACPE, which helps accredit different schools of pharmacy and your continuing education. The American Association of Colleges of Pharmacy. Most pharmacy professors belong to this association, and they learn about changes in what we're supposed to teach you. And the American Foundation for Pharmaceutical Education, which promotes research. So if you want to get a grant to do a research project, these are the folks to go through. I would note that as far as education and regulatory issues, for the quiz, you need to know that the pharmacy labor supply has been reduced because of the transition from the BS to the PharmD as the entry-level degree. So when that change from the BS degree to the PharmD occurred back in the 1990s, there was a big dip in the number of applicants to pharmacy schools. That has started to pick up in recent years. So again, the pharmacy labor supply has been reduced by that transition, at least early on. Going on to pharmacy technicians, their role has expanded. They assist the pharmacist in serving patients. They maintain medication and inventory control systems, and they participate in the administration and management of pharmacy practice. The CPHT certification, there are approximately 250,000, and they get paid about close to $13 an hour. The training includes 600 contact hours over 15 weeks, and they have to take a pharmacy technician certification exam. I should also note that they need continuing education, and you may want to, after you become registered to teach pharmacy techs, the CE that they require. There are 3 types of e-pharmacy and internet pharmacies. I should point out that when you talk about a pharmacy that is actually located like on a street and is open to customers coming in, that's called a brick and mortar pharmacy, whereas an e-pharmacy is one that does its business online. Mail order model is a full service. The RX is from an unaffiliated physician, is filled and mailed to the patient. Other services and products are available on the website. There is information and counseling, services other than dispensing for a fee. There's information and counseling via a 1-800 number. Prescribing and dispensing, the patient may complete a medical survey online. Physician reviews the survey and prescribes the prescription desired. In class, I'll talk about an online pharmacy that provided Viagra to patients over online, and patients had to fill out a survey. There was a newspaper in Chicago who tested this survey, and they entered the data for an alley cat. And the cat, they punched in all the information, like the cat was like 20 pounds, name was Felix the cat, and they still filled and mailed the prescription to Felix the cat. So there was some concern that these surveys to get physicians to prescribe and the pharmacist to fill this whole online was kind of bogus. There were fees for the survey, the physician, the prescription, and the shipping. Again, like with Felix the cat, there was fraud, ethical and safety concerns, but usually this is occurring outside of the U.S. There's something called the VIPS, the Verified Internet Pharmacy Practice Site. It's a voluntary program of the National Association of Boards of Pharmacy. It certifies internet pharmacies based on 19 criteria that you can find in your textbook. The VIPS sealed display on the pharmacy's homepage that you see online links to VIPS information about that pharmacy. Some states require dispensing pharmacists to be licensed in the same state as the patient, which causes problems if you have an online pharmacy serving a number of patients in different states. There's no federal legislation as of yet on the use of the VIPS, mandatory use of the VIPS. And that's the end of this podcast.